Yes.
Okay.
And we're streaming on YouTube.
Great. Just changing your name there. And then if you wanted to record, then we can start. All right. Good morning, good afternoon, good evening, everyone. We are very excited for you to join us today for another Biodesign and Public Health webinar. I believe it's the fourth in the series that we've had so far. I'm Dr. Candace Carpenter. I'm one of the co-CEOs of the Boston Congress of Public Health. I'm very happy to bring this to you. And then I'd like to pass this off to my colleague.
Hello, welcome everyone. My name is Dr. Circe Lecomte. I'm co-CEO of BCPH with Dr. Carpenter. Very excited to be here with you today and to learn more about this amazing technology and how it can help improve sexual health and well-being.
All right, and so I'll do a brief introduction, but I will not steal the thunder for Dr. Maria Yoloko, who is CEO of Vulvi, as well as a world-changing urologist as well. But I'll go ahead and give it to you, Dr. Yoloko.
Hello. Hi, everyone. My name is Dr. Yoloko. I am a board certified urologist that specializes in sexual health, which means that I take care of the medical and surgical management of sexual dysfunction for all genders. I am one of 7 in the world able to do what I do and have the formal training that I have. I'm also really passionate about healthcare delivery and access to healthcare. And my favorite question to ask is who is not at the table and how can we bring them to the table? And so combining those lenses is ultimately what brought me to creating a company called Vulva AI, which we will talk about through this. But I will show you first how I got to the idea to create a company by first going into myth busting. So there are so many myths in sexual health that are so pervasive in our healthcare system that we don't even know about and we never think about it. So today we're going to go through some fun things and play this little game. So like I said, I am a specialized in comprehensive sexual health. Like I am one of 7 in the world. I also am an international award-winning sexual health translational researcher. I define how many nerves are in human clitoris. We are also mapping out the rest of the vulva, how it relates to disease, and we'll go over some research there. Often I lecture at all over the world trying to teach people about the vulva, how it works, because unfortunately our doctors are just not being trained. But if we actually step back and out of the CV, this is actually who I am. I like to believe I'm a sexual health Sherlock. If you have any sort of sexual health concern, I will figure it out. If you have been suffering for years and years and years, I'm the person people come to for help. And that experience has really shaped the course of my life. I also identify as a hot girl scientist. So what that means is actually created by Dr. Shamika Thorpe, who is an amazing researcher out of University of Kentucky, I believe. And she coined this term, and she is a sociologist and professor that studies the sexual health of Black women. And as a Black woman myself, I think it is very important that as we are doing research, we are including everyone in the research process. So that is how I shape my research, is that who's doing the research actually matters to the outcome that you get. And we'll talk a lot more about that. I'm also obsessed with medical history. I'm obsessed with history in general. I've always been that person that's like, but why? Why do we do things the way that we do it? If it doesn't make sense, and you'll see in healthcare, there are a lot of things that statistically do not make sense, and yet we keep doing it. And I am that person that's like, why? And the best way to figure out the why behind something is to go back in history and figure out who started the trend and go from there. Because medicine is unfortunately really traditional, and we need to stop. Like, I don't know, tradition is great and can be done really well, but it oftentimes isn't done very well. I'm also a systems nerd. I love figuring out why systems work and why they fail. Some people would call that being a professional hater. I call it just, wanting the best of everything. An educator. I love educating. I love teaching. And really, my biggest thing is I'm an advocate. Um, and a lot of the work that I do stems around patient advocacy. So we're going to talk about sexual health myth busting. And so we're going to go through several myths and we're going to tie it back into how this actually directly affects your healthcare. So myth number one, the clitoris has 8,000 nerves. So this was So that was the clip for when the study came out. It generated a lot of buzz, which was very shocking to us because the study authors of the study, we self-fund, like we did everything ourselves, and we just did not expect to see how much traction this study would get. And the reason the study was done was really, I kept seeing patients whose nerves had been cut after surgeries, after vulvar surgeries, and they all of a sudden didn't have sensation in their clitoris. And so, because no one had ever thought to look at the surgical anatomy and the course of the clitoral nerves, because in history, that that tissue structure just wasn't important. And if we think about female sexuality, has always been kind of this thing that we don't talk about. It's secret, it's shameful, it's all the things. All of this has clinical implications, right? Society and science go hand in hand together. And if your society is oppressive of half of the population, your science is also going to be oppressive of half the population. And so this study was really born out of a clinical need and frustration of like, wow, we are not doing science when it comes to half of the population. So the actual nerve number is over 10,000. It's actually significantly more than 10,000. Currently, there's just not even good nerve count technology to count all of them. But the clitoris, very well innervated. And that's myth number one. You can see how that myth ultimately was leading to poor patient care. So
So I
now
just
we're going
wanted
to
to
go
let
to.
you know, the when you played the video earlier, we couldn't hear
Mhm.
it. You have to share the computer sound.
Oh,
If you
okay.
want folks to hear that real
Okay. Yeah. Luckily, there's no more sound, but essentially, they just made a terrible joke.
quick.
Is what that was.
So
Um,
maybe we can share the link with folks after.
yes. So myth number two is that young people don't get ED. And so this is something that I would see often. I would have, young-ish men in their 20s, 30s, 40s, people with penises, all the things in my office, and they would be so distressed because they're not supposed to have ED. They're not supposed to have ED. And one of my favorite things is teaching people the actual science behind their bodies. Because actually, if we look at the actual science behind it, is that every decade that you are alive increases your risk for erectile dysfunction by 10%. So 20% of people by age 20 will have erectile dysfunction, 30% of people by age 30 will have erectile dysfunction, and 40% and vice versa, right? So that actually is a huge relief for so many people, right? When we think about sexual health, we think about it from the biopsychosocial aspects of things. Not only is there biology, but there's the psychosocial aspects. And because the way that our society structures sexuality, especially for men and people with penises, if they're having erectile function, it's almost a symbolism of who they are. And so I love being able to explain to them, like, no, it's actually very common and it's very normal. And I'll explain the science behind it because we then go into how does the penis actually work? And so I say that the penis is the best physics lesson you will ever get. And so we'll talk about it as this. So when you when the penis is flaccid, it's actually flexed. All the muscles are contracted. When you have an erection, the penis actually then hyper relaxes, and then blood flow rushes in. So when people over time, as they age, wear and tear, poor health, poor conditions, can cause all the scar tissue to start building up in that muscle. We know a lot about the blood flow, and you'll hear a lot about the blood flow because of things like Viagra and Cialis, blood flow, blood flow, blood flow. Those are very, very, very important. But oftentimes people forget about how important it is to have that smooth muscle relax, because without that smooth muscle relaxation, you can't actually fill up the balloon. And so when we think about the filling up the balloon, when we start getting scar tissue like that, it makes it so much harder for that balloon to relax. If anyone's from the Midwest, if you've ever tried to blow a balloon in cold air, you have to generate way more force to get the balloon to do what it needs to do. And oftentimes it doesn't hyper relax or it doesn't blow up as much as it should. And so explaining those things to patients also really makes it so that they understand that, like, it's not just the blood flow. There are so many other things that can affect it. And this is actually what you'll see if you were ever to do a cross-sectional imaging or an ultrasound of the penis. So this is what a healthy penile smooth muscle looks like. And this is what unhealthy penile smooth muscle looks like. Notice how there's all of these like divots and black areas. So that's actually areas of scar tissue. And so it's really important to understand the physiology and how the penis works, because there are actually targeted regenerative therapies to reverse these things. And so once you know the whole totality of penile physiology, it then makes your treatment so much easier. But really, for the biggest part, it's that mental burden, right? So many people have so much shame around their sexual health, and explaining the science behind it oftentimes makes it so much better, which then ultimately leads to better treatment outcomes. It's all sports psychology, positive psychology, all the things ultimately leads to a better, healthier sexual health life. So myth number 3 is that we're going to bust is testosterone is a male hormone. So if I were to ask people how much estrogen versus testosterone is made in the body, people would say estrogen, right? Because that's what we've been told. And we have like, and this is where facts versus feelings as a phrase that I use all the time. There are a lot of feelings that estrogen is the female hormone and is the most important hormone in women, but the actual facts show that testosterone production is significantly higher. And yet, when we think about all of the information around, you know, hormones and women, it's always estrogen, it's always progesterone. We've completely left testosterone off the table. And testosterone is a really important hormone. It is an everyone hormone. The thing about humans is that everyone makes hormones. We just make it in different ratios. And so to be able to understand that not one hormone defines who you are, but is so important. And it is just like so important. And it brings me to the understanding of the vulva. The vulva is really dependent on hormones, and not just estrogen, as we just saw. It's very rampantly dependent on testosterone. And so we're going to walk you through the process of what happens to the vulva as hormones flow in and hormones flow out. So when you are a kid, you don't have hormones. No hormones are happening. And then so everything looks very rudimentary. You look like you look like a child, right? And then when puberty hits, all of a sudden you get a surge in estrogen, you get a surge in testosterone, which then causes the body to start having or adult sexual organs. So your labia elongates, you grow pubic hair, your labia majora, the fat pads actually start filling in, your vaginal opening, your vaginal opening opens. It's all the things that we see. So people know this, but the fun fact is that a lot of people don't know what happens during perimenopause and menopause. So when perimenopause, menopause happens, your body starts declining in hormone production. That decline in hormone production leads to changes in the vulva. So when and this is happening, y'all, this is happening in everyone. Everyone right now is experiencing this, and yet most people don't even know this. So notice how red, raw, and inflamed the tissue looks. Notice that things are actually shriveling up and shrinking. You're actually reverting back to the pre-puberty standpoint, but with all of these with all these changes that lead to significant symptoms. So when you lose estrogen and testosterone, this causes the tissue to thin, reduce blood flow, loss of collagen and elastin, which means that the tissue doesn't stretch as well. You get vaginal dryness because you don't have secretions because it needs hormones. You also have narrowing of the vaginal hiatus. Literally, the vagina literally starts to shrink. And in some people, it gets so small that they can't even see their vagina and their urethra. Everything is just closed off. Oftentimes, as a urologist in the hospital, when I would get consulted on women or people with vulvas in the hospital, was solely just to put in a catheter because the vaginal hiatus had shrunken so much that they couldn't find anything, right? Changes in vulvar skin, loss of the labia and clitoral fullness, and then also changes in your vaginal pH. All of these changes actually lead to disease states like recurrent UTIs, recurrent vaginal infections, painful sex, dryness, painful bladder syndrome, decreased genital sensation, right? So do you see how that myth that women only make estrogen leads to so much medical incorrectness, medical misdiagnosis, right? And we are actually misdiagnosing so many of these conditions because so many of these conditions could be easily treated, prevented, but because most doctors don't even know that this is what's happening to every person with a vulva's body, we are missing this. So there is a high rate of misdiagnosis or mistreatment of people. So people suffering with chronic vulvovaginal and chronic vulvovaginal issues, so that could be vaginal issues, that could be urinary issues around the world is 960 million people. Or 445 million people are suffering from recurrent UTIs. And the thing is, y'all, 100% of this will happen to everyone. Everyone with a vulva will experience this at some point in their life. This is one of those things that's inevitable. And despite this, 3 doctors to make a diagnosis. 35% of these patients, 35% of the population, or sorry, 35% of half of the population will require 15 doctors or more before they even get the right diagnosis. 7 years to get that diagnosis, and $7,000 out of pocket costs to get that diagnosis. So on average, it takes 7 years to get the diagnosis. I can diagnose you in 30 minutes and get you on the right treatment, right? Why is that? We have in medicine have deemed these patients and deemed anything that has to do with vulvar health as, I don't know how to do it. I can't possibly figure this out. Most doctors are not even trained on this, including gynecologists. And that is something that is so shocking to me, and something that we need to be doing better, because most medical schools do not require female-specific health concerns outside of pregnancy and cancer. Gynecologists are not trained on vulvar anatomy. I come in and I train them. And there are 7 urologists that have been trained on vulvar health, and we're doing our best to spread the message and to do this work and to actually teach doctors how vulvar health relates to the rest of the body's health. And truly, the current diagnostic and treatment guidelines totally neglect vulvar anatomy and physiology. I am such a big scientist and a believer in this that this is a study that I did out of my clinic, that we assessed 330 people that came to my clinic for recurrent UTIs. So these are people that have been in that cycle, that 7 to 10 year cycle. I see them in clinic. I do an evaluation, including their vulvas, and I found that the people with the symptoms of recurrent UTIs, 88% of them, or sorry, 88% of them were actually, their symptoms were because of the vulva and not anything to do with their bladder. Once we treated their vulvas and got their vulvas back to healthy, they no longer had the symptoms, right? So only 12% actually had a urinary source for their recurrent UTIs. But because most doctors don't learn about the vulva, they're not including that in their evaluation. And that is why I'm a big believer that most disease states in the vulva and the bladder aren't recurrent. They're just misdiagnosed. Because when you keep treating something wrong, of course it's going to feel like it's recurrent, but really what it is a misdiagnosis. And so because I love proving people wrong, we also did the study and we looked at over 800,000 people. And we found that people actually taking anti-androgen medications, because we know the vulva now is very testosterone dependent, they actually had higher rates of UTIs and higher risk of UTIs, significantly more than the average population. So this is huge, right? Like this is ginormous. We could be eradicating disease because those changes that I showed you in that video are all preventable with good vulvar care and supplements. And there's health, cheap, easy medication on the market that prevent these things from happening. But if doctors don't even know to prevent these things from happening, none of us are going to do well. So what is happening right now in women's health is a public health crisis. What we are seeing and what we are experiencing and what we are living through is a public health crisis that most physicians are just not taught about the body. It's about half of the population's bodies. It's like going to a cardiologist and the cardiologist doesn't really remember if there's 4 chambers or 2 chambers, right? That is what is happening to every woman as they are getting their vulvovaginal and urinary health concerns addressed. They're going to physicians that don't understand the entirety of their bodies. And this is why I do research. Research for me is advocacy. As someone that is like I say, the buck stops with me when it comes to my patient's symptoms. I am the last resort for many people. And the thing is, I think it's insane that there are people suffering for decades when all they really needed was one doctor to actually know anatomy and physiology. These patients have been gaslit and told they are impossible and they will never get fixed. And I'm like, baby girl, you will get fixed. It's not hard. And it's so, on one hand, it's devastating to see how easy this work could be. And on the other hand, it's also one of the most rewarding things to be able to do a simple exam, know the science, and then be able to change someone's life for the better for the rest of their life. Oh my gosh. And so for me, research is advocacy. I want to create a level of academic rigor in women's health that doesn't exist currently. And it is resistance, right? We are creating and pushing back against narratives that our patients are difficult, they're too challenging to treat. Like it's like, no, these are actually really straightforward. It's the healthcare system that is ruining their lives because we refuse to address our inconsistencies. The only people that suffer are the patients. And so research creates access. And that's why I created Vulva AI. So as one of a few specialists that actually know how to diagnose and treat these conditions, I wanted to figure out how to be able to scale the work that I do and the knowledge that I have to the rest of the world. I also noticed in my time, so I was a clinical professor for 2 years. I saw over 2,000 patients. I built the first sexual health clinic in the United States run by a urologist that took insurance. And so that really opened my eyes to how much of a massive need this work is. You know, in the 2000 patient experiences I heard, I kept hearing the same thing of misdiagnosis, truly malpractice, and then also the fact that there was a lot of feelings over facts. So many of my patients were told to do the most insane things or to like essentially not given the right medical care because the doctor felt a certain way. The doctor didn't stay up to date on the evidence around this work that we do. And so I built Vulva AI it's a predictive AI tool that allows patients and physicians alike to be able to deliver better, higher yield care, particularly around vulvar and vaginal infections and postpartum care. Because I think about AI as the ability to fill in the gaps where humans are failing. And as we can see, there are huge failures in the healthcare delivery to women. And so what we are doing is we are filling in those gaps and educating the masses on a much wider scale. So for on the patient side, we are teaching you about your symptoms, all the things that it could be, how to diagnose, how to treat, how to advocate for your doctor, how to advocate for yourself in the doctor's office so you can get the diagnosis. So many of my patients didn't even know where to start. Like they'd gone on Google, they'd gone on Reddit, but they couldn't figure out what was real and what wasn't. And so when you have been suffering for years, you oftentimes have to be your own healthcare advocate. But because they didn't even have a resource to use, I built it. So Vulva AI is truly a love letter to every person with a vulva in the world struggling to find someone to help them. You can now take that into your own hands. And on the flip side, we built it also for physicians because a lot of physicians do want to be able to help their patients, but because they didn't have the formal training and they don't have the time and the resources to go out and do a year-long fellowship, we bring it directly to them. We teach you exactly how to work these patients up because 1 in 4 people, that's 25% of the population at any given time alone is just suffering with chronic pelvic pain. Recurrent UTIs, then you add overactive bladder symptoms, and then you had chronic vaginal infections. This is affecting hundreds of millions of people. So doctors also want to be able to give good care. They're just not taught. And so this is an ability to scale everything that we want to do, your own vulvar specialist directly into your house. The idea too is that not only are we doing this to ultimately help clinical outcomes, but we also want people to understand that they are their own biggest healthcare advocates and start holding the healthcare system to a higher degree of accuracy, right? A higher degree of care, because as someone that is able to treat all sexes, I get to see how people access care. And I will tell you right now, their medical sexism is real and people access care very, very differently. And because I have this superpower of seeing it all, I want to correct it all and get everyone to equal playing fields. So much so that I created a documentary around this. Like I said, I'm a medical historian. I wanted to understand how did we get here? How is care delivery so poor for half of the population? And so in Vulva Love Revolution, we explore that. We explore how science, health, and tech are merging together to fill in the gaps of healthcare delivery. And I also have a podcast around this, around femtech health and people starting companies within this space because it's so important to hear our stories and to understand the why behind it. Because oftentimes we're trying to fix a problem that society has created, and there's a significant why behind what we do. And so I wanted to be able to highlight these founders um, and have them tell their stories. So that is my time. That is the lecture that I have, and I hope you got some things out of it because I think myth busting is really fun for me, and I love the mental gymnastics of it. But everything is done from a sense of advocacy, right? Even the tiniest little myth can lead to patients suffering for decades. And I want to be able to change that by bringing evidence-based solutions and resources to everyone from their sexual health needs.
Oh my God. Awesome. That's absolutely amazing. Dr. Yoloko. I'm just going to give you like a round of applause now before we even, go to the Q&A. So, I mean, I am very much inspired by you. I know, when I met you a couple months ago, I was inspired, at your pitch then and love this. I mean, and, having gone to medical school myself, I have never seen some of the videos that you've used. So yeah, it is absolutely true and real. But I mean, physician entrepreneur, documentarian, podcaster, researcher, advocate. You're such a, I think, inspiration to many people, but also, Black women who are in healthcare, in public health, interested in entrepreneurship as well. So I wanted to say thank you for that before we go into Q&A. But I wanted to introduce or have our other steering committee member introduce herself, Emmy Dunsford. Emmy.
Thank you so much, Dr. Carpenter. Also, hi everyone. My name is Emmy Dunsford. I'm so sorry for being a little late. I'm in Greece currently, and Greek cafes don't take kindly to hospital Wi-Fi, so that connection was a bit of an issue. But I'm so excited to have heard your feel on vulvi. I honestly didn't even know like the full breadth of everything that you've been working on, Dr. Uloko. Like that's incredible. A podcast and a documentary. How do you have time for all of this? It's incredible.
It's really funny. Everyone says that. And I will tell you, when you are not in the hospital 14 to 16 hours a day, you actually have a lot of time. It creates a lot of time. And yes, I had to, when I first came out of fellowship, I said yes to a lot of things. And I burnt myself out because I was so excited. I was like, I love the work that I do, and you're new and you're young and you're fun. And you want to be out in these streets and spreading the word and doing all the things. But through that process, I learned the power of no and boundaries and only saying yes to things that define your why, right? And so getting really clear on what my why is and what my mission is. And, and sticking to that, and then also time blocking. So it was a lot of trial and error, but it's getting really clear on your why, only saying yes to the things that support those whys, and then prioritizing your mental health and spiritual and emotional health. And time blocking is truly magical. And also, like, I used to stay up for 96 hours at a time on calls. So, again, much easier in a way.
Mhm.
96 hours, that's insane. I honestly,
Yeah.
and now I need to add time blocking to the list of things to Google for time management. If it works for you, then that will be something I'll definitely use. Also, other than, I guess, time management, this is a good intro into like the first question that we wanted to ask you. What were some significant challenges that you had to deal with when beginning Bullseye?
Yeah. So, I think the challenges for me have been being a first-time founder, right? It's learning a whole nother language. In when you're talking to investors, when you're doing business, and it's learning a whole nother language, and just having a spirit of, okay, listen, I'm learning, and learning is sometimes painful, and you're just going to embarrass yourself sometimes, and it's going to be okay. And every single day you show up and keep learning more. And so it takes a lot of humility to constantly learn new things, but I do love learning new things. I think, obviously I'm 0.02% of Black female urologists, which means your work ethic and you're on a different type of scale or stage. And so I'm used to being in spaces where I'm not the norm. And so going from one industry that does have problems to another industry that also has problems with that, it was just kind of like, okay, like just even understanding the landscape of like what I am doing versus who I am. And so, and just kind of understanding the trends of who gets funded and who doesn't get funded, and figuring out ways to work around that. I love proving people wrong. Fight is a really fun thing for me. But also, again, being mission driven, right? Like I get up every morning because I know that someone like I can't even go to the grocery store without someone sharing the most traumatic thing while picking out mangoes. And I'm like, oh, okay, but this is what happens, right? They don't have anyone else to go to. And as soon as I say what I do, someone wants help. And to understand that, like, this is not just about me, this is so much bigger than who I am. And also, like, the real facts is that Black women are dying in gynecologic related issues, right? Like, what is going on there? There is no protection in these spaces. And to see and hear these stories from my patients, to hear this from complete strangers, to keep hearing these stories over and over again, it just continues to fuel me to keep going and keep pushing.
Yeah, that is absolutely profound. I mean, that resonates with me. And when you said like, I'm just trying to go to the grocery store and then the droves of people that need your help. And I imagine that even after this webinar that you've done with us, the things that you're doing, right, that people have never seen before, I'm sure your inbox is going to get flooded with that. But if I can transition to another question, so you talked about some of those challenges and it sounds like in terms of like who you are, right? Like, so you perfect resume, right? Like in terms of, your background, things that you're capable of doing, but then having to grapple, being a Black woman in a healthcare tech space and who tends to get funded. And we know that it is harder for, people of color, LGBTQ people, non-traditional healthcare entrepreneurs to get funded. But if you could tell us a little bit more about in developing Vulva AI, what are some key milestones that you're particularly proud of or milestones that you're looking towards in the future?
Yeah. So, gosh, I think the thing that I'm the most proud of is a spirit of creativity, right? So to go from, okay, I see, so, and this was another reason why I had to leave the traditional healthcare model, just because, like, we love looking at problems, talking about it, and then never doing anything about it. And as a doer, it's like I gotta move, I gotta make things happen. And so I went into tech with this idea. And you know, one of the things I've loved about this process is taking a concept that doesn't exist and then actually creating it, and how hard that is, and to believe in a dream, and believe in something that you can't quite yet see, and then convince people of that dream and of that vision. Will never, I will, I don't, as someone that says she's a professional hater, I will never hate anyone chasing their dreams. I will never hate the process of creativity because it is really hard. And I have so much reverence and respect for people that are able to do this. And as someone that has done it now, I'm like, wow, this was an idea and now it's out in the world, like it's tangible, it's there. So that's a really exciting thing. The other exciting thing is the potential partnerships with institutions. So when I had this idea, it literally came on a walk because I like, not only do I see patients, I do research, I also lecture a ton. So almost every weekend during my academic career, actually, no, I still have my academic career. I'm still very academic. But during my tenure at an academic institution, I was at a conference every almost other weekend, and just trying to teach doctors about this work, and like realizing that that was going to burn me out because it did. And then it's also doesn't actually change practice management, because a lot of these doctors they'll go for an hour, they're like, cool, I learned a concept, but did it actually change how you're seeing patients and delivering care? And oftentimes no. And so when I came up with this idea, it was really a love letter to my patients, of just being like, okay, if the system won't educate the doctors, I'll educate you so that you know how to work in the system. But now there's also this potential collaboration with institutions that are also realizing that, oh, maybe we should be doing good care. And so, that's big, that's huge. And so to be able to pilot all the AI with those institutions, and start those conversations just feels like a really it's just not something I thought would ever happen. I thought it would be much years later once patients started holding institutions accountable. But it's nice that we can build two verticals at the same time.
Yeah, that's
Speaking
absolutely.
of,
Yeah. Go ahead, Emmy.
oh, I was going to say, speaking of holding institutions accountable, let's talk social justice with regards to vulvi. We
Mhm.
wanted to ask, can you discuss the role of social justice in your work there, and like particularly ensuring that all women and people with vulvas have access to quality healthcare?
Yeah, no, I mean, this is, like I said, this is a public health crisis that's happening underneath our noses, right? Like, so many people have inherent trust in their physicians of like, of course, my doctor went to medical school and training and knows how to examine me and knows what is wrong with me. And when I go to the doctor, I'm going to get the right care. And that's the general consensus. And I was that way until 2020 when I did my fellowship. And I was like, oh, I didn't learn any of these names or parts or know that they had functions like it. And I thought that was weird as a urologist. And then I kept hearing the same stories 2,000 times of neglect. I've seen 4 doctors, 5 doctors. My gynecologist has looked, everything looks normal. I look, it is not normal. It's like a bomb has exploded down there. I've even had gynecologists in my stirrups saying, "Oh, I didn't even know that tissue had a name." And I was like, and I think that speaks to the larger issue at hand of like, we're just not training our doctors, and it's so scary and it's unfortunate. And the only people that are suffering are the patients. And so, yeah, I mean, and so 51% of the population just isn't getting good health care. And that is a social justice issue in itself. And then so, because if you think about it, I do the breadth of menopause, I do sexual health, all of this is things that are considered not in the purview of our traditional medical model when it comes to delivering gynecologic care, but 100% of people are going to go through menopause. So who's taking care of them? And like, so like Oprah Winfrey didn't get the right medical care. Oprah Winfrey was having heart palpitations caused by her menopause. She has the best cardiologist in the world, and he missed it because he didn't learn about menopause. He didn't learn about women's bodies and how it changes and how it affects other things, right? So if Oprah, one of the most visible people with access and privilege in the world, isn't even getting the right care, what is happening to the poorest of the poor? Because again, I always think about who's not at the table. And so when this is affecting everyone, no matter your social standing, your racial demographic, your financial demographic, religious, all the things, this is huge. This is a huge social justice issue.
Yeah.
When you mentioned the about how medical students aren't getting training besides cancer and pregnancies for women and people with vulvas, that's insane. That
It's
is,
the
I know
per
so many people going to medical school like in this term, and it's not changing.
Yeah, unfortunately, that's the key. We did a survey, and less than 20% of the trainees, whether they're medical students or gynecology trainees, urology trainees, ER trainees, internal medicine, they didn't know anatomy, didn't learn anything. Like only or 20% knew, 80% didn't, right? That's problematic. Again, it's like going to a cardiologist that only knows that you like thinks that you have 2 chambers and it's like, I don't know, maybe 4, I'm not sure, right? That's what's happening to our healthcare, like to people in our healthcare system. It's unfortunate, and we need to do better. I mean, we need to fully change the curriculum. One thing I am really excited about is the power of medical students. So a lot of medical students have been holding their institutions accountable and saying it's kind of wild that I'm not learning anything about my own body, and have been demanding the institutions and taking it upon themselves even to create curriculums and bring in, physicians that are in the space to teach these courses, but this should be just standard universally. But look at the power of change, right? Of holding people accountable has led to institutions actually starting the process to learn this. And so this is why I speak so much about this, because once you start seeing it, you can't unsee it, and you want to create change. And it's oftentimes we are the ones that are going to be the ones creating change. Speaking truth to power and demanding for better care for everyone is what's going to create the change.
I just had a quick question about social justice and issues around like sexual health and women's anatomy. I think one of the things that, and perhaps I'm off in this, but it seems like when it comes to outside of just sheer functionality of the vulva, of the vagina and the like, the idea of pleasure or women not having pain is kind of seeming kind of extraneous. And I remember when I was taught about like menstruation, it was like, well, you know, it's supposed to be painful and you just need to get over it. And I was just wondering if you could speak a little more to that. And I feel so inspired by your discussion today and empowered as a someone who experiences this. And I just was wondering if you could share a little more.
Yeah, yes. So that I think you speak to the wider narrative of um, acceptance of pain, right? So I think that's a perfect example, right, of how society, like how science and culture interact, um, and sometimes trump each other, right? So if you look at the James Marion Sims is considered the godfather of gynecology,
Mhm.
um, and has very distasteful practices and exploited Black women's bodies, oftentimes performing surgeries without any general anesthesia. And so this is the epigenetic trauma that happens and is passed down in traditions, right? So now you have a woman on the table, you're doing a procedure on her, she's writhing in pain, and you're just telling her, and the physicians are like, keep going, keep moving. It's okay that they have pain. So now that physician then trains another apprentice, that apprentice trains another apprentice, and that just continues down the line. And so, and we know right now that there is a huge problem. There's way more conversations around the acceptance and the normalization of pain, women's pain. The not the documentary, but the podcast, the retrievals, the documentary about endometriosis, like there's way more conversations that are happening now about this, but it's still that general feeling that like, yeah, no, that person's just complaining, or it's normal. We've normalized pain in women. When on the flip side, I'm going to talk about two different procedures. So I, as a urologist, do vasectomies, which is a contraception method, a permanent contraception method, and IUD is also it's not permanent, but it's a contraception method, both procedural. When I do a vasectomy for a patient, they get sedation, whether it's just with like local sedation, or we'll make sure that they're comfortable. No matter what, they'll make sure that they're comfortable. They can do it in the operating room. Typically, we'll do it in the clinic, but for the most part, they are comfortable chatting, free of pain. That is the expectation. IUD, however, we've all heard the story of the person that's like passed out after an IUD, right? That's not normal. We have to stop allowing that. And whenever you talk to physicians that put in IUDs, they're just like, yeah, I don't know why they were screaming. I'm like, okay, I can tell you why, because if you understand the cervix that you're dilating, which is essentially the same as a contraction, you're now stretching something that has triple innervation. A highly innervated organ is not going to feel good when you dilate it. And even though it's just a little dilation, it's the same thing as a contraction. But because it's again normalizing, we're normalizing women's pain. It's like, well, that's just what happens to them. And it's like, no, let's reimagine a world where we can make them comfortable during procedures. And so it's something, I'm a chronic pain specialist, so it's something that I just that this grinds my gears, and I'm trying to elevate the conversation and push back against this understanding of like, yeah, it's just painful sometimes. It's like, no, we don't do this on the other side for most medical procedures.
That is, go ahead.
No, I was just I'm just blown away to hear this articulated and in such a way that is so approachable and accessible, and it feels very empowering. But let my colleague take over.
Good.
Yes.
Yeah, no problem. I mean, I have so many different thoughts, Maria, and just thinking about you, like when you said what we do on one side, we don't do on the other side, right? And then the need, just thinking about medicine in general and having to re-examine the things. What are we doing for men versus what are we doing for women? And why is that? Why is that the standard practice? And why do we never question it? Because we're not taught to question. But then they also, back to Emmy's point about medical education, the tension that seems to exist, that medical students are demanding that they have this kind of education about vulvar anatomy, but even kind of like harkening back to a webinar we had with Justin from Equality MD, like being able to learn about the LGBTQ community in their medical education as well. And if you could speak to, because I know that you do also treat all kinds of patients, kind of speaking to not just women but other types of patients, and kind of like how you might tailor your approach to them.
Yeah, it's really, it might be so simplistic in a way of like, what genitals do you have? Which genitals do you want? How can we make them healthy? That's really all I think about is like, and and it takes away so much societal, cultural things out of it. Like, obviously that's going to be there, but I start with a foundation of science, right? Of like, what do you have? What do you want? How can we optimize it? Period. That's where we start. And then we bring in, because she's a liberal arts major, and so she like she has a lot of humanity and people skills. And so we bring in all those things too, because I ultimately want their goals and their unique experiences to align with that. But when you kind of think about it like that, it really it makes everything much easier. And when you just stick with the facts, I'm a big believer in facts over feelings to um, when it comes to this work, because unfortunately, a lot of the feelings surrounding women's health, vulvar health, is just kind of like, why does it even matter, right? Or like, that's normal, or, we normalize things that shouldn't be normalized. And so I like to bring a lot of facts into this space, and that's just how I do it in a lot of things. And also knowing full well that there's still just so much that we don't know. And so I like to bring us a spirit of curiosity too. And like having those conversations with patients of being like, listen, there's a lot of data around this, but we can definitely try something. And if you feel comfortable and explain it, yeah. And also going out and understanding that there isn't a lot of data, so you have to go out and create the data yourself. And so there's a lot that goes into every patient interaction. But I always start it with, what do you have? What do you want? How can we make it? How can we optimize it? Period.
Awesome.
And honestly, we should get into the audience questions as well, because there's a lot of really interesting ones. Beginning with, are there more misdiagnoses for Black women or women of color? I know you briefly touched on this, but yeah.
Yeah, no, I mean, if we just understand how healthcare works and just the huge disparities, the racial and economic disparities that people experience, I think there's a report that just came out, I believe today, that showed that racial minorities have worse outcomes in every state, like from a healthcare standpoint. And so, if this is affecting all of the population, as you start adding intersectionalities, 100% you're going to have a higher rate. I now, knowing what I know and kind of seeing how healthcare does not deliver evidence-based care to women for a lot of conditions outside of pregnancy and um, cancer, I'm not surprised by the stats. And we know the stats are not great. And if we look at the stats, and especially if we start looking and adding in intersectionalities, that's why we keep seeing the stats that we're seeing. But oftentimes we want to blame the patient, or oh, they didn't, they come from this neighborhood, they come from that neighborhood, or they're not healthful, all the things. We oftentimes don't look at ourselves as physicians as to how are we also contributing to this problem.
Absolutely. I'm just looking at some additional questions as well. So one was a simple one. Where can people listen to your podcast? Can we have that in the chat?
Yes, so you can listen wherever podcasts are found. It's called Salvaging Sex. It's on Apple, iTunes, Spotify, iHeartRadio. It's everywhere in 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 the ethers.
Love it, love it. And then the next one is someone was curious about your position on genital cutting, I think in particular for females.
Yeah, so okay, so this is what I talk about, and I actually have a podcast about this episode on this particular thing. So, I think it's one of those things where why I let this is why I question tradition. I am Nigerian. I grew up in a very traditional patriarchal family and religiosity everywhere. And so there was some good stuff around that, and then also a lot of bad stuff around it. And this started my questioning of tradition. Like why do I have to do this? And being one of four and the only girl, I was treated very differently than my brothers. And I got to, again, witness it. I was like, no, they're getting that, and I'm getting this worse deal. And so, since as a kid, I've always questioned traditions that don't make sense. And also, I think there is a very interesting westernized, patriarchal, paternalistic attitude towards these things, right? Because for uh, female genital mutilation or female genital cutting. I saw there was a little debate about that. It's colloquial. It's FGM. It's like official terminology now, but female cutting is still something that people say. So both parties were correct. There's just one a little bit more politically correct term. Um, and so when we think about it in their society, in their culture, it's symbolic. It's a status symbol, right? Or there's different explanations as to why it's still done. And so I like, again, think about things from, I'm not here to cast any judgment. I'm here to educate you and make the best decision for your body. And if that looks like educating the moms about, okay, well, this is what FGM does. Like, it can cause urinary issues like chronic urinary infections, very severe infections. There's no real medical, um, there's no real medical uh, benefit from it. And so explaining the potential risks of it, and letting that person make their own decisions is truly all I can do. And so obviously there is no medical benefit from FGM, but there is a lot of cultural significance for it. And I think the key to eradicating it is education, and it is understanding and questioning traditions and why we are doing things for it, while also allowing them to make their own decisions. And hopefully one day everyone will be able to make a decision from an informed and powerful point, but also understanding that it's a nuanced conversation. There's just no like, absolutely not burning feminists like that. Obviously, I'm an intersectional feminist and I want people to have bodily autonomy, but I also understand culture and cultural significance and what that can mean for an individual and how that affects their decision-making process. And so all I can do is give them education around things, and then they're ultimately going to be the ones to make their own decision.
That was so beautifully put too, with respect to everyone's cultures and decisions. Thank you, Dr. Yoko. Um, I guess we also have one hand up from a Luciano. Um, if possible, would we be able to unmute them?
Um,
Oh, great.
Luciano, I was able to bring you forward and you're able to speak if you'd like. If you just have to make yourself unmute. Just
You can type it into.
yeah, if you have a little.
While we're waiting, Ellen asked, how do you handle religious beliefs of patients if they are contrary to your medical advice or regimen? Again, I think that's a really interesting, like, I love that question because it's super simple. Once they leave my office, I'm done, right? Like my only job is to educate you and help you make informed decisions. You're like, everyone comes in with their own um everyone comes in with their own unique needs and experiences and wants and desires and dreams and the culmination of who they are I can't see in my office, but I can explain things to them and I can explain the science to them and they can do what makes the most sense for them based on that. So yeah, that's how I think about it of I'm not here to make decisions for you. I'm here to support you, educate you, and then give you all the tools to make the best decision for yourself and your body.
We have another question from someone named Christopher Brooks, and I'm going to bring him forward to ask his question.
Uh, I'm sorry, can you hear me?
Yes, hi,
Yeah.
Christopher.
Okay, thank you. Good afternoon, and thank you for this very, very informative discussion. I'm a medical anthropologist, but I'm also an Africanist. I've been to medical school, and I really appreciate your very even-handed explanation of female genital cutting. I don't use the term or that expression, female genital mutilation, because that is an evaluative statement from my standpoint. And I know a lot of women get very worked up over it or what have you, but I do see a sensitivity issue and that we have to, the way in which you explained it is that it is something that takes place over a period of is gradually phased out, etc. I really appreciate your putting it that way because it is often a very incendiary discussion. And when I discuss it, or what have you, and why that might be, a culture might embrace that, again, it's often dismissed.
Yeah, no, I think it's such a thank you for that. It is something that I can't like I can't speak to their unique cultural significance, right? Like I'm not in a culture that does that. And yet I have a cultural things that don't necessarily benefit me either, but I fully understand why. And so I always do think I take my lived experience and bring it into my evaluation of just being like, hey, I might not understand this, but all I can do is explain the science behind it, what to expect, and you get to make your own decision. And I thank you for that because it's a tricky conversation, and I always want to make sure that I am speaking from a place of of humility and science.
Awesome. Well, thank you so much, Dr. Maria Yakula. We're a little bit over time, so we'll have to wrap up. This has been excellent discussion. I would say probably one of the most provocative ones we've had on like sexual health for sure. So thank you again so much. And yeah, definitely people follow the podcast, reach out to her for any questions that you might have. And we thank you so much for joining us for the fourth Biodesign and Public Health webinar. Thank you again.
Thank you. Bye.
Thanks for joining, Emmy.